Thank you all for coming today. We really appreciate you attending this session. It's very important. We've had a lot of requests for this session, so we're excited to be able to bring some experts today to share their wisdom with us. So before I get started though, my name's Ashley. Most of you who've been here know who I am, but I'm from an organization called Your Choice. We are a nonprofit organization that specializes in alcohol and drug prevention education. And our organization was founded by my family after going through my brother's substance abuse. So really our goal is just to provide education and hope that by doing that, we can help future generations. We do offer lots of programs, both virtually and in person. And with the COVID, we have done these webinars, which again are recorded on our website if you want to watch them. We have podcasts, we have blogs, we have a virtual bedroom tour. So that is all available to you after this webinar if you want to learn more. Just a few housekeeping items. This is a webinar format, so we won't be able to see or hear you. So if you do have a question, there is a Q&A button on your tab that you can put your questions in there, or you can also use the chat box as well. Myself and Katie and Sandy are both here today to help answer questions, so feel free to drop those in there. If you would like continuing education credits for attending today, the fee is $15 and you can purchase those after the webinar, or if you already have purchased them, just please make sure that you complete the survey at the end of the webinar. That is necessary for those CEU credits. We'd also like to thank our sponsors for making these webinars possible. So Pro Healthcare, Rogers, Freighter, as well as Rosecrans for providing the funding for these, and then also Rosecrans for providing those CEU credits. And with that, I am going to turn it over to our presenters today.
Wonderful. Good morning, everybody. My name is Dr. Amy Kuechler, and alongside me here is Andi Lewis. She's one of our senior clinicians. We both work at Rogers Behavioral Health out at the Brown Deer campus. I am a psychologist for child and adolescent programming and have various programs that I oversee that include younger children. So we'll take individuals from 9 years old all the way through 18 with a wide variety of symptomology from ADHD, aggressive behaviors, depression, anxiety, and substance use. We work in a partial hospitalization program and an intensive outpatient program. And I just want to bring it up as a frame of reference because I think a lot of our suggestions are going to come from our clinical experience here. We'll be talking at the end of the presentation about some interventions for you guys to implement, hopefully in your home, in the schools, or in your own treatment facility. So a partial hospitalization program is from 6 hours a day, 5 days a week. And then the IOP programs are 3 hours a day, 5 days a week. So just want to give you a frame of reference in terms of that, because not everybody is overly familiar with the different levels of care for treating mental health. So with that, I'm going to get started. And I thought I had my screen shared, but I did not. So let me go back and do this again. I'm not very, very familiar with Zoom, so bear with me. I'm hoping that everybody can see it now. Andi, shake your head if you can see it. Okay, wonderful. All righty, so let's get started. So I'm going to start with just some basic facts about ADHD and what ADHD is, because there's a lot of pop culture references and ideas of what ADHD is. You're often going to hear, oh, I have ADD, and I'm going to talk about that in a minute, how that is actually not even a diagnosis. So there's a book out there called the DSM-5, and it presents the criteria to meet a diagnosis of a mental health disorder, and ADHD is within that booklet. And so some of the basic symptoms that you'll have to have in order to meet criteria for this diagnosis or this disorder is a persistent pattern of inattention and hyperactivity. You'll want to have the symptoms. They need to be present prior to the age of 12. They need to be present in more than 2 settings. You might notice or hear somebody say, oh, they're only like this at home, but at school they're great, or vice versa. It's important that these symptoms are showing up in 2 or more settings, and I'll explain why a little bit later on as well. There also needs to be clear evidence that the symptoms of ADHD, which I'll get into great detail here in a second, are impacting the quality of life. So it's impacting the social aspect, the academic, and if for an adult, and occupational functioning. And it's important that these symptoms are not better explained by perhaps another mental health disorder or a physical disorder. Okay, so we're going to start with just the category of inattention. Okay, so in order to meet criteria for ADHD inattentive type, you would have to have 6 or more of the following symptoms, and they would have to persist for about 6 months. So I'm going to take a second and give you some examples of each one as we go through here. So making careless mistakes. That would be an example of overlooking or missing details, or the work that a student might be handing in is inaccurate. Having difficulty sustaining attention in tasks or play. So having difficulty remaining focused during lectures or conversations or lengthy readings. Often does not listen when spoken to directly. So it might seem that they're drifting off and not paying attention, focused on something else that's going on in their mind. Having difficulty following through on instruction and failing to finish schoolwork. It's kind of self-explanatory. Having difficulty organizing tasks and activities. Or avoiding, dislikes, or reluctant to engage in tasks that that require sustained mental attention. So maybe avoiding schoolwork or homework. Often loses things that are necessary for tasks and activities. So losing their school materials, maybe they're losing pencils, books, even their phone or their keys. Is often distracted by extraneous stimuli and is often forgetful on daily activities. So they forget to do the chore that they're supposed to do, or if they're running an errand, you ask them to go to the store to pick up something, they might forget what that item is. The second category then we've got is hyperactivity-impulsivity. So again, we're looking at 6 or more of the following symptoms that have to have been in existence for at least 6 months. Going through these with a couple examples as well. So often fidgets with hands or feet or squirms in their seat. Often remains or leaves seat in a situation when remaining seated is expected. So you might see that very often in the classroom, getting out of their seat. Running or climbing in a situation when it's inappropriate. Unable to play or engage in leisure activities quietly. So you might have that person where you're trying to work independently and they're always talking, or maybe even talking to themselves. Is often on the go and acting as if it's driven by a motor. So unable to be comfortable with just sitting still for an extended period of time, constantly feeling like we need to move our feet or our hands. Talking excessively, blurting out answers before blurting out an answer before a question has been completed. So they might cut off somebody else's sentence or interject their own thoughts into the sentence. Often difficulty having to wait for their turn, and often interrupts others or intrudes on conversations. So they're butting into the conversations or even an activity. So I bring up those 2 basic components because there are 3 types of ADHD. So you can have ADHD predominantly inattentive type, which is kind of the equivalent to when you hear people say, hey, I have ADD. They're really referring to ADHD predominantly inattentive type. Then there is ADHD predominantly hyperactive impulsive. And then you can also have combined, which means you're meeting criteria for both of those symptoms put together. I wanted to give you a little bit of statistics on how prevalent ADHD is. So about roughly 10% of all children aged 3 to 17 were diagnosed with ADHD in 2008. 13% of males and 6.6% were female. And as you can see, as the ages increase, so does the prevalence. So you go from just around 1% from ages 3 to 4 up to 13.6% from ages 12 to 7. There are also some other factors that have been noted to correlate with individuals who have ADHD, particularly children. So if they come from a lower income family, there is a greater chance that they could develop ADHD. As you'll notice, individuals, family income less than 35,000 have a higher percentage rate of having children with an ADHD diagnosis versus those who are making a larger income. Also, the presence of who's in the home can make a difference. So if neither parent is in the home, so they're either raised through perhaps foster care, or an extended family member, the percentage, as you can see, is 17.8% versus when both parents are in the home, the prevalence rate decreases to 8.8. Ethnicity is also a potential risk factor. So individuals in the African-American community can have a 12.8% chance. And then as you notice by the second bullet point there, if you're biracial, there is a greater increase in ADHD than in a single race individual. ADHD often is found in correlation to other diagnoses. So if somebody has ADHD, there's a 64% chance that they're also probably diagnosed with another disorder that's found in the DSM, the most prevalent being behavior and conduct disorders. And then obviously, as you can see, followed by anxiety, depression, and then also the autism spectrum disorder. So how do you know if you have ADHD? Again, it's very common for somebody to come up to us and go, hey, so-and-so was in class, they're not paying attention, they must have ADHD. Or I'm trying to get my child to sit at home and do their homework, they're not paying attention, they must have ADHD. And my biggest recommendation for anybody who might suspect it is to have a formal diagnosis. So in this formal diagnosis, you're typically seeing a psychologist, and they're going to be providing some valid measures to assess your child's symptoms. You're going to be collecting collateral information from all of the individuals who are working with the child. So we're looking at parents, we're looking at schools, we're looking at therapists, coaches, anybody who might be interacting with the child on a regular basis to be able to get some feedback about how they act in the different settings. It's important to have a formal diagnosis as well, because it can help rule out other possible conditions. So mental health or physical conditions can also present as with similar symptoms. Anxiety can present with some restlessness, where it may be perceived as, oh, they're hyperactive and inattentive, but actually they're dealing with a lot of anxiety. So it's important for us to then screen for those coexisting conditions, such as depression, anxiety, and behavioral problems. It's also important for us to rule out the possibility of a learning or language disorder, especially within schools that might be more noticeable, where the child is not paying attention in the classroom, constantly getting out of their seat, moving around. But part of that might be because they're not comprehending the material due to a learning disorder. And then also we want to rule out potentials for any physical conditions that might be causing these symptoms. All right, so I'm going to start with kind of where we're going to find ADHD in the brain. And so you have this frontal lobe in your brain. It's the most sophisticated part of our brain, and what makes us evolutionarily superior to other animals. This frontal lobe, though, actually doesn't fully develop until your mid-20s. And I'm going to get in more detail here in the next couple slides on what the frontal lobe actually manages and how important it is for us. But it's ultimately the center for our executive functioning. So it's going to be in control of our movement, our intelligence, our reasoning, behavior, memory, and our personality. All of these things are developing through our childhood, adolescence, and early adulthood. And that's why it's so vital and important for us to take a look at what the expectations are developmentally, and also how that could play a role in somebody with ADHD. So with executive functioning, you will notice that there's a lot of tasks that they do that our frontal lobe is managing. So it's managing our attention, our working memory, reasoning, planning, organization, our forethought, impulse control, initiation, judgment, emotions, social behaviors, sexual behaviors, language, and problem solving. I bring all of these up because that's a lot of things that are being controlled by this frontal lobe that's still being developed until you're, like I said, until your early 20s. But I also bring it up in the context of multitasking. You might hear individuals always say, oh, they're so bad at multitasking, or you might yourself think, man, I can't multitask, I can't pay attention today. And I'm going to go on a slight little soapbox on multitasking and challenge individuals to recognize that you're actually not attending to multiple things at once. Multitasking is more the ability to switch your attendance quickly to different tasks. So it's really difficult for me right now to give this presentation and then also attend to perhaps a text message that's coming in on my phone. The reality is I'm attending to this, and then if I look down at my phone, I'm attending to the phone and then switching back real quick to where I left off in this presentation. And so Multitasking isn't really the ability to attend to multiple things at once. It's your ability to switch your attention and then go back to using your short-term memory or your working memory to go back to immediately where you were in that last item that you were focused on. All right, so when we're talking about the frontal lobe, like I said, it's working on working memory and recalling and holding on facts. So like I said, if I get distracted by something else, can I jump right back in and know exactly where I am in that presentation and what I'm talking about? Your frontal lobe is also going to be responsible for activation, arousal, and effort. So it's what's going to get you initiating and starting a project and completing the project. It also helps you with complex problem solving. So it's going to help with being able to take away a situation, dissect it out, analyze it, have an idea of what possible consequences or solutions could be. Your frontal lobe, as you see in the quote at the top, is often referred to as your emotional control center and home of your personality. So it is what is kind of managing some of your emotions, your ability to tolerate frustration, to think before speaking and not have that impulsive reaction come out of your mouth. And it's also your own self-talk. So being able to talk yourself down, think about what are going to be your future actions or behaviors. I bring these things up because it's really important to notice that these are things that are learned. These are things that are developed over time, and the importance of the development of that process. So for example, frustration tolerance, which is something that's being held and managed within your frontal lobe. The importance of learning how to tolerate a frustration, to be able to know, okay, this is an uncomfortable feeling and I can sit with it. Your brain is sending a signal going, I don't like this, I don't like how this feels. But then to have the wherewithal and knowledge to know I can sit and hold on and respond through, I do not have to impulsively react to that uncomfortable feeling. Those are things that are taught obviously through parenting, within schools, within just development over childhood. So I can't emphasize enough the importance of all of these tasks and how nurture is playing a large role into being able to develop these skills. Okay, so speaking of development, let's talk a little bit about what is developmentally appropriate for a child or an adolescent. So societal viewpoints have definitely changed over the years in terms of what somebody's expectations are to attend to information, and also their kind of overall behavioral, emotional, and intellectual abilities. So academic expectations over the years have obviously increased. I'm of the generation where a 4.0 was the highest GPA you could possibly get. It is now my understanding that you can get quite a bit over a 4.0 with various college credits that you can take in high school. So the academic expectations are incredibly high. So think about the frustration that might have of asking somebody who's 16, 17 years old to be doing a college class that might be meant for somebody who's a little bit older. Can I tolerate and manage the additional load when maybe I want to go hang out with my friends? Social media is a significant contributor to inattention, is a significant contributor to potential problems in frontal lobe development. With social media, we have created an environment where we get immediate feedback. We no longer have to delay gratification. We no longer have to sit with something. I put out a message and I can immediately have 500 of my friends respond, yes, they liked it, or no, they didn't. It is also changing the way in which we're looking at ourselves. So instead of having this introspection in terms of our perception and values, a lot of it is being based on feedback from other individuals. So that is most certainly also changing our personality and impacting that frontal lobe. Expanded attention has changed over the decades. Back in the day, when the only thing to attend to in the evening was perhaps a TV or maybe a radio in the background, we've now got TVs, iPads, different tablets, different phones, you name it. And just regular conversations that are happening within the household. So there's a million things that are constantly distracting individuals and grabbing their attention. And when you might be hyper focused on one thing and somebody else is calling your name, perhaps mom's calling, hey, I need you to pay attention, and you're not, that's not necessarily an ADHD issue. It's the fact that we're asking our children to attend to 10 different things at once, and that's just not feasible or do they have the mental capacity to do so? Behavioral expectations have also changed over the years. As somebody who's working in mental health, there seems to be a lot of concern about somebody who's younger, of like, if they're a little bit silly or if they're a little bit defiant, and what that might be, that must be that there's something mentally wrong with them. We have such high expectations on our children, and enacting them, having them behave appropriately and properly, that sometimes the developmentally playfulness and fun can be lost, and it's so hyper focused on needing to act like an adult when we have a child's brain. Emotional expectations are something that has changed over the years as well. I go back to that decrease in frustration tolerance, as well as just being able to tolerate an uncomfortable feeling in general. Over the years, you hear everybody gets a trophy for participating. It's questionable whether that's really the best way to approach some of these things. Sometimes it's better for a child to recognize that loss happens. How do I deal with the loss? How do I work harder in the next time, and keep going? And some of that will help with the focus and attention and hyperactivity that you can see. The other component is pop culture. Our society likes to diagnose and explain away behaviors versus looking at what some external factors might be. So it's easy to say, oh, this child is just depressed, versus looking at potential factors that are going on, whether that's within peer relationships, the household, and whatnot. So it's important for us to really take a full case conceptualization of each person and take a look at, is this really a diagnosable mental health disorder, or are there some other factors that are contributing, and how has society played a role in that? And it's also, taking a look at what's developmentally delayed due to either a physical or mental health issue. So you might have a 13-year-old in front of you that you want and expect to be able to act like a 13-year-old, but really they're a little bit more slower and acting more of like a 7-year-old. Is that due to some kind of health condition or potentially a mental health diagnosis that went undetected for many years? So as you can see, ADHD has definitely increased over the years. So a couple of factors regarding that is there is a strong genetic component, so it is inherited, as well as some other environmental factors that they've discovered. So lead exposure, premature birth, low birth weight, and brain injury can all contribute. And I also encourage you to think about some of the societal things that we just talked about, or I just talked about in the last slide. So now let's move on to a little bit of the neurochemical aspects of ADHD, because it isn't all just external and nurture. There's also a nature part to this diagnosis. So we have these neurotransmitters in our brain that help send various chemicals and signals between our neurons, or the cells within our brain. ADHD has a decreased level of two specific neurotransmitters. One of them is dopamine, which is involved in learning, movement, mood, pleasure, and reward. And the other is norepinephrine, which is involved in mood, attention, focus, dreaming, learning, impulse control, processing, and some autonomic functions. And I bring this up because what some of the behaviors are doing in an individual is trying to find ways to compensate for the low dopamine. So I'm going to give you an example here, and I kind of wrote it down to help me better memorize it here. But so you might find yourself starting off with a task with a lot of enthusiasm and then losing interest quickly. That can be a level, that can be an effect of potentially having low dopamine. So if you're hyperactive, or if you're having hyperactive ADHD or combined type ADHD, you might be focusing on trying to find a behavior that's rewarding that dopamine system and keeping that system in check at all times. And so you're looking for high stimulus activities, such as playing video games. It's probably really difficult you've seen a child, it's difficult to tear them away when they are glued to a video game. But biologically speaking, it is filling the brain with the neurotransmitter that's making them feel that pleasure and reward system. So when they get to less boring tasks, such as math homework, it's very hard to pay attention and want to do that when you aren't getting that reception that fill the dopamine into the brain, where you might in doing something that you can enjoy and hyper focus on, such as a video game. Some reasons that neurotransmitters in the brain can be in flux might be due to developmental issues, puberty, it can be hereditary, and it can also be a predisposition to illnesses or other influences. Get asked a lot working with substance use, is there a potential for you to have an increased risk of substance use if you have ADHD? So I'm going to go over a little bit of that in the next few slides. So there is technically a risk, an increased risk to develop a substance use disorder if you have an ADHD diagnosis. What the research is finding is that you actually have a greater chance of going from initial use to actually developing a pattern of abuse over time. So where somebody who doesn't have ADHD, let's just say hypothetically, would take a year to get to a point where their use has become to a level that is abusive, it might only take 3 months, hypothetically. Again, I don't have a specific date or time on that. I'm just giving you an example. Research has also shown that there is a potential to consume alcohol, marijuana, and tobacco in particular at an early age. The strongest correlation between individuals who have been diagnosed with ADHD and a substance use is with tobacco. Something that's a little bit interesting to point out, though, is just because you have a diagnosis of ADHD, it does not mean that you are going to develop a substance use disorder. Instead, the risk factors just happen to be very similar. So somebody who has ADHD often has problems in school. So they're avoiding school, poor academics, they're having issues at home, maybe increased arguing, they're having issues with peers, they're having conduct disorders, they're truant or skipping school. And there might be a familial pattern, or so the genetics we were talking about. Those are also the exact same risk factors for somebody who does not have ADHD to develop a substance use disorder. So those individuals, again, have school problems, family problems, peer problems, conduct behavior problems, and also show a family pattern of the behavior. So the main key that I want you to know by seeing this slide is intervention is the most effective way to ensure not only risk factors of not developing a substance use disorder, but also to address the ADHD symptoms so that you're not potentially increasing your risks of also developing a substance use disorder. There are various medications that are out to help treat ADHD. So you've got stimulants, which are probably the most popular that are out, and you see the various names. And then you have some non-stimulants. Non-stimulants are typically used when individuals either are having an unacceptable side effect from stimulants, or they're finding that the stimulant has been ineffective. Some of those potential side effects do include a loss of appetite, trouble sleeping, increased blood pressure, dizziness and headaches, and a stomach ache. These are the typical side effects that we see in the patients that we treat at our clinic. They're typically subside within a couple of days once the child's body has gotten accustomed to the medication. There are some more significant side effects that can occur, which is increased moodiness, nervousness, tics, potentially worsening psychiatric issues. The key here is to make sure that you're tracking those side effects and making sure that you're providing that feedback back to the person who prescribed those medications. So then the next question I get with substance use is always, did my child, is using a stimulant going to increase my child's potential of having a substance use disorder? So as we stated earlier, individuals who have ADHD have a greater risk of starting to smoke cigarettes at a younger age, and are twice as likely to become addicted to nicotine. So there is definitely a correlation between ADHD and tobacco use. Now, ADHD treated with stimulants, though, have demonstrated with research that they are no more likely to increase the use of cocaine or abuse other stimulants than those who did not use stimulants to treat ADHD. Meaning, if you're taking a stimulant that does not increase your risk of developing a substance use disorder or abusing your own stimulant medication. Actually, individuals who had ADHD and were treated with stimulants were actually less likely to engage in illegal drug use than adolescents who weren't prescribed stimulants. Okay, so that's the overview for ADHD. I'm going to turn it over to Andi now, who's going to talk about some of the interventions and treatments that we have and recommendations that you can utilize within your setting.
Yeah, so treatment for ADHD, research has shown that a multimodal approach is best, meaning collaboration between providers, school, parents, and the patient or the kid is best. So behavior therapy, we're going to dive into. Medication, she already talked about. Family involvement, and then school interventions are all important. So in a study done, they looked at kids that were already diagnosed with ADHD from ages 4 to 17 and looked at the treatment that they received for ADHD. And some of the examples of the behavioral treatment and the skills that they found were used were school accommodations that we'll get into later, some form of behavioral treatment and skills training, parent-delivered therapy, social skills training, peer interventions, and then cognitive behavioral therapy. So what they found was that treatment for ADHD can include behavior therapy and medication. And then for children ages 6 and older, it was recommended by the American Academy of Pediatrics that it's preferable that you use both behavior therapy and medication. For children under 6, they recommended to start with behavior therapy as the first line of treatment. So we can start with the interventions for parents. So one of the most important things we do here, and that's recommended, is to make sure parents have knowledge of what ADHD is. So knowing what the symptoms are, what treatment options you have out there, and then what strategies you can use to help your kids. And then participating in behavior therapy. So it's most effective to use these things in collaboration. So in behavior therapy, the kids can learn the skills to develop some better self-control and improve their self-esteem. And then parents learn skills to help facilitate them doing that at home and at school, and also to provide appropriate support to help them. So what does that look like? So within the home, we recommend a lot of structure and consistency, because again, that frontal lobe isn't developed yet. And so they need some help with that. So what does that look like? That's having house rules, emphasis on organization, helping them establish a clear routine. It's also important to make sure your expectations of them are very clear, making sure they understand what their expectations are and that you're all on the same page. Expectations should be pretty objective. So again, it needs to be clear, very concrete, because that's where their brain developmentally is, and it needs to be simplistic. So with ADHD, it's hard to focus. And so if your rules are too lengthy or your expectations leave room for argument, probably not going to be too successful. You also want to focus on praising the positive behaviors. So what this looks like is often we're recommending that parents let some of the smaller things go. So if you're focusing on getting them to get to school on time, well, let's focus on that more and praise the behaviors that are helping them get to school on time, rather than maybe the few swear words they let out during that. That's something that can be talked about later. So anything they do correctly, you want to reinforce that, because again, you want to facilitate them establishing higher self-esteem, and you want them to know that what they just did was a positive thing. And then planning ahead. So anytime you can, make it so that they know what to expect, you can expect them to respond better. So having those routines, making sure there's minimal distractions when they're doing their homework. So maybe turning off the TV, not having everyone in the same room as them, giving them clear choices and not giving them too many choices. So do you want to do your homework first, or do you want to do a chore first? Giving them, you need to facilitate some more of the dialogue between them to help them choose. We're going to get into a behavior system on the next slide. And then using frequent goals and rewards. So you should have daily goals that they're working towards, something daily they can earn. And then you can also look at long-term things. So, if you attend school or for this many days or whatever you're working on, you want there to be a reward attached to it, because that's how their brain is working then. Okay. So charts and point systems for the younger kids, visuals are huge. So these are the things that help them to organize what your system is at home. So on the next slide, I have an example of a behavior plan, and this can be modified. Again, I work with the younger kids, so this can be modified for teens though. So an example of a behavior plan was you can earn your electronics are huge. So you can earn your phone each day you complete your schoolwork, complete your 3 chores, and use respectful words. So it's helpful to have a visual. Oh, do you want to go back to the last slide? Sorry. It's helpful to have a visual of this. Sometimes you can keep it on the refrigerator so that you know and they know what the expectation is. So again, this is very clear and specific. It provides them an opportunity to earn something positive. It's consistent. And the other big part of it is parents sticking to it. So if this is your expectation for them to earn whatever it is, if you go against that and they don't do what they're supposed to and they still get the reward, you're reinforcing that they don't have to do those things. So a lot of times in the beginning of kids coming through our programs, this is where parents struggle the most because, maybe they did 9 great things, but they didn't do the one thing, and they want to go back on it, but we want to reinforce the positive behaviors the most. These are just some examples of things we've used. So the first one is what we call a sticker chart, and it can be implemented at home or at school. It doesn't have to be so concrete here, but this example shows that the timer we have a timer in the group room or in school, and the timer keeps going as long as the kids are doing what they're expected to. So working on an assignment, sitting in their seat, all of these things that they're practicing. And if they, let's say they get out of their seat without permission, okay, then the timer pauses until they correct the behavior and are sitting in their seat. As soon as the timer goes up and they get through whatever designated time you guys decided on, they get to take a break from the classroom. So this helps to break up those longer periods of homework. Sometimes this can help the kids get through a class. So it's like, I really hate math. Okay, so if I just focus on math for 45 minutes in school, I get to go out into the hallway and just chill out by myself for 5 minutes. It gives them something to look forward to, and it helps keep them on track. We would also recommend that these breaks, if they're working towards breaks, they're very structured. You go through it before so they know exactly what they can expect. So it's not like I get to go to the lunchroom and hang out with my friends for 5 minutes. I get to walk up and down the hall, use a punching bag. I get to whatever you decide, but it just needs to be decided before the break. And then in the middle is an example of a morning routine checklist. Again, visuals are huge. It's just another cue for them to remember to do the tasks that they're expected to do. I recommend creating it with the kids because they often like to add their little personal touch so that they feel invested in it, and it's not just like adults are telling me what to do. And then family rules, kind of self-explanatory, but going through it as a family is huge, and establishing what behavior we all expect of each other and what are people expecting of me. So with all of these things, it's really helpful to have the kids be a part of it so that they feel like they have some control in it. And visuals help to build those organizational skills, and it helps to keep it objective. So you can refer back to in the middle of some argument or something not going well. Well, remember, these are your expectations. What can we do to help you right now? And then when it comes to the discipline part of it, so you can be very specific. It looks like you didn't do the 2 chores you said, or we agreed upon. So no, you don't get your phone tonight, kind of a thing. So that's at home. And then at school, the interventions are behavioral, classroom management, organizational training, and then some special education services and accommodation. So it looks in the classroom, it looks a lot like the recommendations I just went over for home. So praising the appropriate behaviors. So for example, here in the group room, if we see one kid talking out of turn a lot, I will praise the next kid for raising their hand. Good job raising your hand. So one, we're indirectly trying to correct that behavior without just calling them out for not raising their hand. And then when they do raise their hand, praising them for doing that. And then there's also, you know, it's helpful to have that structure and give them an opportunity to reflect on how they're doing. So this is an example of our communication sheet we use here, but the idea behind it is that after every group, they have to process how they think they did, and we have a point system here too, but it allows for you to praise the positive behaviors that they did, like great job staying in your seat. Next time or next group, I want to see you participate a little bit more. So you can give them that positive feedback and also some of that constructive feedback. And again, rules and structure. So in most classrooms, especially with the younger kids, it's very clearly outlined on the walls what the expectations are, having a schedule, giving frequent feedback, and, you know, as much as you can stick to a schedule or give the kids a heads up, if something's going to change, would be helpful for them. Again, rules should be pretty simplistic. So stay seated, raise your hand, participate without getting too wordy. And then building time management and planning skills. So this can look like assignment notebooks are huge when you're struggling to keep track of everything you're supposed to do, especially then with ADHD. They need help with that. So helping them structure out their assignment notebook, someone going through it with them, allowing breaks to get that movement, get that energy, give them a change of scenery just for, I mean, our breaks are typically 3 minutes, but with schools, we recommend about 3 to 5 minutes. So, you know, making sure they know what their options are for these breaks. So it could be an energy break, taking space alone, talking to someone, using a coping skill like fidgeting or coloring, just making sure everyone's on the same page. Using timers. So again, I'm going to work on this for 15 minutes. Sometimes the timer can help sustain that attention. And then we usually recommend having some staff member check in and out with the kids to plan for the day and then plan for home. So catching them at the end of the day and being like, let's go through your assignment notebook. Let's look at what you need to do tonight to just reinforce some of that organizational stuff. So, and then providing choices. So anytime you can offer choices will be helpful. So if you say, what do you want to work on first? That could flood them. So giving them options. All right, it looks like we have math, social studies, and science to work on. Which one do you want to work on first? Okay. And then, so some of those interventions can be made with schools without any sort of formal plan written up, but sometimes it can't depend. It usually depends on, you know, resources at the school, staffing, budget, all of those things. So if they can't, then sometimes we'll help families look into a 504 plan with schools. And a 504 plan, it's that lower level intervention. So a lot of what I just covered technically goes into a 504 plan. Some schools can just do it without the formalized plan. And sometimes not. So then sometimes they require more. So if you're requiring extra time on tests, IEPs can offer one-to-one support, breaks, more one-to-one support, individualized instruction. Sometimes they get pulled out for certain classes. We always help advocate, because the biggest thing is everyone needs to be on the same page. And so if your kid's struggling in school, you want to be able to talk to the school team about what's going on. You want to involve therapists and professionals from outside of there so that everyone can get on the same page about what could be helpful for the kids.
I think I somehow went back on accident. I have no idea why. I apologize, Andi.
No, that's okay.
I'm not a Zoom expert by any means. But that is it for us. I know we were encouraged to leave a little bit of time at the end to answer some questions. So I'm going to stop sharing my screen so we don't look so small and you just look at a blank slide. Stop sharing. Okay.
Awesome. We do have questions for you. Okay, so I'm just going to let you guys take the lead. I will ask them and then whoever wants to answer them. For the combined presentation, do you have an overlap of the categories with 3 symptoms in inattentive and 3 symptoms in hyperactivity, or do you need 6 in both?
You need 6 in both.
6 in both. Awesome. Okay, how do you navigate siblings who don't need the additional supports and accusations of being unfair when you have different, stricter expectations for the child with ADHD?
Andi, you want to take that with all your family therapy?
Sure. This is a big thing that comes up. So part of what we recommend is making sure you're also checking in with the other siblings. So when one sibling's really struggling, it's easy to forget about the other kiddo. And a lot of times what they need is some validation. Most of these things, you can hold them all to the same standard. So I usually recommend, like, those other kids are probably already doing the thing. So if the expectation is be safe, do your homework, do one chore, and then you get your electronics for the kiddo with ADHD or who is struggling, the other kid can probably be held to the same standard because they're already probably meeting it. But just acknowledging that both of them are doing it, that's typically what I recommend.
Yeah, that's great. In our area, it appears mental health providers do not want to diagnose kids for ADHD until the age 5. Can you help me understand the thinking? I work with preschoolers.
Yeah, I mean, it's kind of relating back to the stuff I was mentioning of there's just so many different potential factors that are influencing a child's behavior. And the last thing you want to do is provide a diagnosis that's inaccurate and then potentially not only have labeled that individual, but start down a trajectory of medications and other interventions that aren't necessary. So, children are born with their own temperament. They're born with their own kind of style, and part of parenting is in, school, preschool, all of these factors. Babysitting is forming and molding that. And so we also just don't have the cognitive, the brain development at that point where I would even feel comfortable making that diagnosis. So I think it's a matter of just waiting to see. And once you get into these different environments and structured environments, how do they respond within those settings? So it's just being on the side of caution, basically, is the gist of that, I'd say.
Yeah. I know from my experience, my oldest son in 5K, they were like, oh, he needs to be medicated. He's so crazy. And we're just like, well, he's a 5-year-old boy. And today he's absolutely not ADHD, but just the situational thing. I'm like, well, I'm glad we didn't put him through a bunch of tests because he's not. So I understand that.
And I think that kind of speaks to what I'm hoping anybody gets out of this presentation is we always want to justify the behavior because it can be very frustrating if you're a teacher or a parent or whatever the case is, that hyperactivity, that inattention, and we're all stressed to the limit the last year. So it can be a very frustrating experience when you just want your child to sit and listen. But that doesn't mean that it's necessarily a mental health issue. It doesn't mean it's a disorder. There's a lot of factors that are going on. And so I think for me, I just always want to caution people before automatically jumping to that conclusion, because there's a lot of, I can tell you right now, my phone's going off. I've got emails that are coming through. I've got a messaging center that's coming through. I shut them all off, but somehow they all still keep popping up. So it's just that natural tendency. And I'm like, it's just a natural distraction. This isn't necessarily that my brain's not doing what it's supposed to. We're just expecting it to do way more than we're capable of.
Yeah. It was mentioned earlier that the prefrontal cortex does not fully mature until mid-20s. Is this final maturation, I can't even say it, delayed for those with an ADHD diagnosis? So do they mature slower?
I don't have official stats on it. I can tell you anecdotally, for many of the individuals, if you have a mental health disorder, it does slow down the progression of the development. Hence, we want to have intervention sooner than later. Even depression can slow down the development. I mean, depression, anxiety, all of these mental health disorders all have a component of your neurotransmitters not being appropriately distributed or being re-uptake in your brain. So without things kind of being even keeled, that definitely does impact one's ability to fully develop. And in addition, if you're not intervening and creating better patterns, you're actually training, the brain is always, let me take a step back. The brain is always trying to become the most efficient it can possibly do. So it's going to find the pathways to complete a task as efficiently as it can and prune off any other additional ways in which you could look at something. And so that idea of practice makes perfect is absolutely true. So if you've been dealing with an emotion, and this is the pathway in which you've been dealing with the emotion, this is what your brain's been triggered to do to manage it. So you don't like the feeling of feeling uncomfortable, so you impulsively react, or you get out of your seat, or perhaps you use a substance. This is a pathway in which your brain is training itself to do, hence the need to intervene and retrain the brain into something else. So it impacts its maturation for sure.
Next question. My 10-year-old is embarrassed about her diagnosis, and that is the root of a lot of her resistance. For example, she absolutely refuses fidgets at school, but she fidgets with everything. How do you help normalize ADHD for your child while honoring her desire for privacy?
That's a great question. So I think part of it is, again, working with that child and asking, what are some solutions she might have? What does she think would be helpful? So you want to come in and, empathize and be like, all right, I can see why that you might feel embarrassed or whatever. And then once she feels heard, being like, my concern is you're still struggling with these things. Here's my data to support how you're struggling with these things. What are some potential solutions? So, because a lot of times the kids can come up with things they think that might work. A lot of times it's not feasible, but maybe, we've created very discreet ways for kids to ask for a break. It's like I've created a modified bathroom pass for one of the kids at the school. So all the other kids thought she was going to the bathroom. She was actually going out in the hallway to use I don't even know what she was doing, but some sort of fidget. So you can get more creative with that, but really almost flipping it back on her, like, well, what's going to help you then? Because this isn't working. And that's something that a therapist can definitely help with, because that's part of the resistance that we usually deal with. So.
Oh, great. Turning on to school people. As a school person, we sometimes find out kids have received a diagnosis of ADHD without the therapist/doctor having asked for any feedback from the school. What are your thoughts on that?
I don't want to. So I'm not going to talk about how anybody else might come to their own conclusions. And I saw a question in there even about, like, again, diagnosing with a 3 or 4 year old. Each practitioner can take their own approach. I would disagree with that as somebody who has done testing in the past and looked at ADHD diagnosing. I rely highly on the school's feedback. So I think it's important. Again, the diagnosis alone requires you to have information on how the child acts in 2 different settings. And the time they're going to spend the most in the 2 places is home and school. So I think it's a very valuable input.
Okay. How about natural supplements you have found helpful outside of prescriptions?
I don't prescribe, so I don't know of any. I couldn't actually answer that question.
Okay. Let's see. When your child is in the process of being diagnosed but is not yet, how can you get teachers to understand the child and get them to cooperate with coping techniques that will work for you at home?
That can be a struggle. So again, just having that conversation with parents in school and helping to facilitate to make sure everyone's on the same page. So we do school meetings where sometimes the parents are involved in that. Otherwise, that's just through family sessions, but where everyone's on the same page and looking at, look, this isn't working. So really coming in with as much evidence as you can get, like, well, my kid's failing math. They're failing every time they do this. So as much data as you can provide is going to be helpful, because then you have the support, you know, in a data sense, but then also just making sure that everyone's included in the conversation.
And I think if you're a parent who's just trying to work solely with the school, trying to either get a therapist involved, getting your primary care doctor involved, getting some other people who can maybe help educate and advocate for your child would be helpful, because it can be very overwhelming as the sole person who's trying to advocate changes within like the school setting. And I know on the school side, there's a lot of individuals who may need assistance, and funding and resources just aren't there. So trying to be as much as a teamwork as possible.
Okay. And I think that goes along with the next question. Like, so if your child gets diagnosed, the school IP is set up, but then the parent feels overwhelmed. What can they do?
Yeah, just having those conversations and making sure that you're speaking up. So a lot of what we do when we attend IEP meetings is we prep with the parents before. So what are your things that you want to make sure are talked about or provided, or what do you want to advocate for, and really coaching them through that so they feel confident to be like, this is what I think my child needs, or this is what you said you were doing and then we're not doing it. And then working with schools to also help them feel confident in their answers. So what are your resources? What can you do? What are the limitations, so that everyone can stay focused and try to advocate for what they think.
Okay. Let's see. Can you comment on the difference between male and female adolescents when it comes to taking medication or therapy? Any differences?
In what? I guess I don't know
in male. Is there any difference between male and female being diagnosed and taking medications?
I think there's a higher prevalence in males than there is in females. So it's more likely for a male to get diagnosed with it. And then I do not know what the numbers are in terms of who's being treated with medications and who's not, but I would anticipate that that's very similar. So more males, so there's more diagnosed.
Okay. I think then the last one is just, how do you set up a 504 plan? Is that through the school then?
Yeah, that is through the school. A lot of times schools will try out a 504 first before they will initiate an IEP, because if you want the least restrictive environment. So if they can be helped with a 504, they would prefer that.
Okay. I think that is all of the questions. So, is there parent support groups for kids with ADHD?
Not that I know of, although it would be fantastic if there.
I would encourage anybody to go onto a website that is chad.org. Chad spelled, Andi, help me out here. CHADD.org. Chad spelled with 2 Ds. It is an outstanding resource. You're going to find a lot of the information we just shared with you coming from there. The CDC also has information on their website on ADHD, but CHAD is an organization where you actually might find some at least online blog support groups.
Okay, that's awesome. Great. Well, thank you guys so much for today. All the information, I know we've gotten so many requests just around this topic, so I think it answers a lot of questions, and especially with the substance abuse, since that's what we work in, we always get questions. So very, very helpful with that. For those of you who would like CEU credits, please make sure you fill out the survey at the end. When you leave the webinar, it should pop up. If you're on a phone, it won't, but don't worry, I'll be sending the link later. If you don't need CEUs though, we still like your feedback. So we are giving away a $50 Amazon gift card at the end of the series. So if you take the survey, you can get entered to win that. Next week, we have a parenting webinar, text, tweets, and everything in between. And then March 3rd, we're having lessons learned from marijuana legalization. So those are our final 2 webinars of this series. We did record the presentation, so if you want to watch it again, it will be available for us or for you by, I would say, by tomorrow. Sometimes it takes us a little longer to download them. And again, thank you to our sponsors, Rosecrans, Pro Healthcare, Rogers, and Freighter for making this webinar possible. And of course, thank you to our presenters today for providing all this information, and to everybody who attended our session today. So we hope you have a good rest of your week.